Hello everyone, this is Dr. Ashley Utchison from the Academy of Online Radiology Education. I work at Baylor College of Medicine in Houston, Texas. This month, we have curated some interesting literature on breast imaging. In this study, authors sought to determine differences in diagnostic accuracy in patients who underwent initial screening with digital breast tomosynthesis and synthetic mammography, with repeat screening of digital breast tomosynthesis with synthetic mammography or full field digital mammography, compared to patients who underwent screening with full field digital mammography alone. Nearly 33,000 women underwent repeat screening, with approximately half receiving digital breast tomosynthesis and half receiving full field digital mammography. Cancer detection rate, recall rate, positive predictive value of recall, and detected cancer stages were compared between enrolled women undergoing repeat screening and the control group, which was screened with full field digital mammography alone. The cancer detection rate was significantly higher for women who underwent repeat screening with digital breast tomosynthesis and synthetic mammography compared to the control group. The proportion of cancers stage 2 or higher was significantly lower in both repeat screening groups when compared to the control group. The authors concluded repeat screening with digital breast tomosynthesis and synthetic mammography detected more cancers compared to full field digital mammography screening, in addition to detecting fewer stage 2 or higher cancers. In this study, authors sought to compare differences in diagnostic performance of radiologists when distinguishing cancer from non-cancer on dynamic contrast-enhanced breast MRI, while using conventional software versus an artificial intelligence system. 19 breast imaging radiologists interpreted 111 dynamic contrast-enhanced breast MRI examinations twice. For the first interpretation, breast radiologists were supplied with conventional software, including kinetic maps. For the second interpretation, radiologists were also provided computer-aided diagnosis software with artificial intelligence analytics. When using the AI system, radiologists' average area under the receiver operating curve improved from 0.71 to 0.76, which was statistically significant. Sensitivity improved from 90% to 94% with the use of the AI system when using US-BI-RADS 3 lesions as a cutoff point. However, specificity did not differ with conventional and AI software. The authors concluded that AI system software improved radiologists' diagnostic performance when distinguishing cancer from non-cancer on dynamic contrast-enhanced breast MRI. In this study, the authors sought to examine lactation-related and breast cancer-related FDG uptake patterns in patients with pregnancy-associated breast cancer and patients without breast cancer. 16 lactating patients without breast cancer served as the controls, and 16 lactating patients with pregnancy-associated breast cancer were retrospectively assessed. FDG uptake, which was measured in SUV mean and SUV max, was measured in breast tumors of patients with pregnancy-associated breast cancer and in normal physiologic lactating tissue in both study groups. In the control group, uptake in the physiologic lactating breast tissue was typically high, with an average SUV max of 5. In pregnancy-associated breast cancer patients, breast tumor uptake was high with an SUV max of 7.8, which was at least 3 times higher than physiologic uptake in non-affected lactating breast tissue in these patients. When compared to the control group, pregnancy-associated breast cancer patients demonstrated a 59% decrease in FDG uptake in non-affected lactating breast tissue, which was statistically significant. The authors concluded that physiologic uptake in normal lactating breast tissue is significantly lower in patients with pregnancy-associated breast cancer compared to controls. In addition, tumors in pregnancy-associated breast cancer patients are well seen on PET-CT due to high uptake within the tumor on a background of comparatively low decreased physiologic uptake in non-affected lactating breast tissue. In this study, authors sought to determine the utility of adding different synthetic B-values when assessing tumor visibility on diffusion-weighted imaging. 84 women with enhancing lesions on dynamic contrast enhancing breast MRI underwent additional breast multiparametric MRI. 3 radiologists evaluated diffusion-weighted imaging examinations with acquired b-value of 800 and additional synthetic b-values ranging from 1,000 to 1,800 to determine lesion visibility and preferred b-value for interpretation. A b-value of 800 received the highest image quality score, but b-values ranging from 1,200 to 1,800 received higher scores for lesion conspicuity, particularly in patients with dense breasts. Although diffusion-weighted imaging was more specific for breast cancer detection compared to dynamic contrast-enhanced breast MRI, dynamic contrast-enhanced breast MRI was more sensitive and accurate than diffusion-weighted imaging. Of note, the modality with the fewest false positive cases and highest accuracy was multiparametric breast MRI. The authors concluded that synthetic b-values increase tumor conspicuity, especially in patients with dense breasts. In this study, the authors sought to determine the relationship between heterogeneity of enhancement kinetics on breast cancers on dynamic contrast-enhanced breast MRI and occurrence of distant metastatic disease. 128 patients with invasive breast cancer underwent pixel-based dynamic contrast-enhanced MRI analysis to generate time signal intensity curve patterns. With this technique, various time signal intensity curve patterns, including non-enhancement, washout, plateau, and persistent, were categorized and quantified as percentages within each breast tumor. Compositions of time signal intensity curve patterns were compared between patients with and without distant metastasis. In patients with distant metastatic disease, the predominating time signal intensity curve patterns were persistent and non-enhancement, with an area under the receiver operator curve of 0.87. The authors concluded that increased heterogeneity in breast tumors is associated with distant metastatic disease. In time signal intensity curve patterns, analysis can assist in predicting distant metastasis. In this study, the authors sought to establish the diagnostic utility of contrast-enhanced ultrasound in BI-RADS 3 and 4 lesions with calcifications. 168 breast lesions with calcifications were detected on both mammography and conventional ultrasound and classified as BI-RADS 3 or 4. Each lesion was subsequently evaluated with contrast-enhanced ultrasound and given a contrast-enhanced ultrasound score to generate a re-rated BI-RADS, which is also known as the contrast-enhanced ultrasound BI-RADS. When compared to conventional ultrasound, diagnostic accuracy and sensitivity values of contrast-enhanced ultrasound BI-RADS significantly improved. In addition, contrast-enhanced ultrasound BI-RADS diagnostic efficacy was significantly greater than conventional ultrasound. The authors concluded that the addition of contrast-enhanced ultrasound and the evaluation of BI-RADS 3 and 4 lesions with calcifications significantly improves diagnostic accuracy. In this study, authors sought to assess the positive predictive value of biopsy of digital breast tomosynthesis detected BI-RADS 4 architectural distortion. 179 digital breast tomosynthesis and digital mammography screening and diagnostic mammograms demonstrating BI-RADS 4 architectural distortion were included in the study. 63 of these cases were pathology-proven malignancies with a positive predictive value of biopsy of 35%. There were no significant differences in positive predictive value of biopsy between mammogram type, presence of microcalcifications, or personal history of breast cancer. When an ultrasound correlate was present, architectural distortion was more likely to be malignant. In addition, positive predictive value of biopsy increased from 26 to 44% if architectural distortion was detected on both digital breast tomosynthesis and digital mammography, compared to breast tomosynthesis alone. The authors concluded that digital breast tomosynthesis detected BI-RADS 4 architectural distortion has a positive predictive value of biopsy of 35%, and likelihood of malignancy increases with an ultrasound correlate and when architectural distortion is detected on both digital breast tomosynthesis and digital mammography. For more details, you can read our blog where you can find links to the original publications. Please feel free to share your thoughts and questions with us on the Breast Imaging Forum, and we'll see you next month.